I'm Dr. Stephen Lipshultz, and I'm the Chairman of the Department of Pediatrics at the University of Miami Miller School of Medicine and the Chief of Staff of our Holtz Children's Hospital. I'm a pediatric cardiologist. We have about 18% of our population that we care for are obese. About 35% are overweight, and about 7% are morbidly obese. And this is very similar to what's seen around the United States. We find that diet and exercise in an isolated setting really is effective in about 15% of cases. Its sustainability is not particularly strong. We have a unique program at the University of Miami called Crunch Time, where we have children come in and work with an exercise physiologist for children, work with a nutritionist, one-on-one for a 12-week, several time a week program, followed up by at home. A year later, we find it's highly sustainable in terms of weight reduction and increased physical activity, change in body composition, and improved quality of life and school performance. And this is what we do for our children who are highest risk, because we feel that with close supervision, it becomes a very effective treatment for children with obesity. In children, we have an increasing prevalence of type 2 diabetes, but it's still very much a very late in the course of childhood obesity before we see that. That is in contrast to adults. And so we usually look at children with obesity to see if they have other risk factors. We've found that, for example, in about 15% of all teenagers, they have the risk factors for the metabolic syndrome. We find that in children in the 8-year-old range to 10-year-old around the United States, it's also present in about 5 to 10% of children. And even in younger children, 3 to 6 years of age, we find that metabolic syndrome risk factors are present. Because these track to adult life, and because it involves abnormalities in lipids, abnormalities in other cardiovascular risk factors, we increasingly use that as determinants of who are the highest risk children for subsequent premature cardiovascular disease, and structure our interventions initially with our Project Crunch Time exercise and nutritional counseling, and if needed beyond that, in those particularly high-risk children, we will institute pharmacotherapy with medicines to specifically address issues, whether it is an issue of abnormal lipids, cholesterol, if it's an issue relating to other factors such as higher blood pressure, whether it's an issue related to having an increased blood sugar. And we've increasingly in adolescence found that for children and teenagers in particular who are refractory to non-medication treatments and to medication treatments, metabolic surgical options have been highly effective in our hands in adolescents with bariatric surgical procedures. There are recommendations by national organizations supporting the increasing use of statins in children and teenagers for specific indications, and the safety profile is good. The testing and studies have been over the last decade and look very good. We also can tell you that it's limited follow-up. Having children or teenagers on statins lifelong, the effects are not particularly well known because that treatment has not been used for long-term use. And so it is a big question that we face in terms of what does it mean if we start this type of therapy early in terms of toxicities and late effects. But we are using it increasingly. It does work effectively in children. We really do not know whether using it in children and teenagers, in fact, results in a reduction in risk of premature cardiovascular disease, because a lot of the endpoints for a 10-year-old child may be 20 or 30 or 40 years later, and those studies are not available. The recommendation to use statins in children at high risk is something that's only come about in the last few years. The University of Miami Miller School of Medicine has been one of the leading centers in the trying to look at, are there biomarkers that we can validate with longer-term studies as surrogate endpoints for premature cardiovascular disease? In other words, can we make measurements years ahead of time that help us identify which groups of children are at greatest risk for future development? Over the past year, the Framingham Heart Study released for younger adults, age 20, what the 30-year risk is of having a myocardial infarction, a stroke, or an ischemic event. And we find that based on data and evidence that this is increasingly helpful as we try to screen which children, which teenagers, which young adults may be at greatest risk for premature heart disease. There are other large studies that are very difficult to complete that take decades. One is called the P-Day study, and they have also identified putting in markers that can be measured in teenagers to say which children are, and which teenagers and which young adults are most likely to have atherosclerotic plaque in their coronary arteries even as teenagers. And so increasingly these are being used to identify higher risk children and teenagers that might be worthy of further study, further investigation, and potentially treatments to alter the course of subsequent disease.